REM Sleep Behavior Disorder RBD is a type of sleep disorder. Look at this picture shows that behavior during REM sleep, then brain involvement, look at this, and muscles. Detail going on. Introduction. REM Sleep Behavior Disorder RBD is a parasomnia, a type of sleep disorder characterized by abnormal movements, behaviors, emotions, or dreams that occur during rapid eye movement sleep. Unlike normal REM sleep, where the body experiences temporary paralysis, individuals with RBD act out their dreams, which can be vivid, intense, and often violent. This disorder is increasingly recognized for its association with neurodegenerative diseases. A definition: REM sleep behavior disorder is a condition characterized by the loss of normal muscle atonia during REM sleep, resulting in the physical enactment of dreams. These behaviors may include talking, shouting, punching, kicking, or jumping out of bed. Etymology: the term REM sleep behavior disorder derived from REM rapid eye movement, the sleep stage recognized by vivid dreaming and behavior disorder, indicating abnormal actions during this phase due to loss of muscle atonia. Epidemiology: REM sleep behavior disorder affects approximately 0.5% to 1% of the general population, with a higher prevalence in males over the age of 50. It is more commonly observed in individuals with neurodegenerative diseases, especially in Parkinson's disease and Lewer's body dementia. Types: 1. Idiopathic RBD occurs without any identifiable underlying causes, often a precursor to neurodegenerative diseases. 2. Secondary RBD associated with neurological disorders, example Parkinson's disease, Lewer's body dementia, multiple system atrophy, or use of certain medications, example antidepressants, especially SSRIs. Causes: 1. neurodegenerative diseases, especially say in equilibriopathy, like Parkinson's disease, multiple system atrophy, Lewer's body dementia. To medications, example SSRIs, TCAs, MAOIs. 3. Brainstem lessons, particularly in the bones. 4. Withdrawal from alcohol or sedative hypnotics. 5. Genetic predisposition, less common. Risk factors. 1. Age, more common in individuals over 50. 2. Sex, higher prevalence in males. 3. Neurodegenerative diseases. 4. Use of certain medications. 5. Head injury. 6. Exposure to toxins. 7. Family history of parasomanias or neurodegenerative disorders. Complications. 1. Injury to self or bed partner due to violent movements. 2. Sleep disruptions and poor sleep quality. 3. Daytime fatigue. 4. Progression to neurodegenerative disease. 5. Psychological distress, fear of sleeping due to violent behaviors. Pathophysiology. In normal REM sleep, muscle atonia is maintained by inhibitory signals from the bones. The sublaterodorsal nucleus to spinal motor neurons in RBD. This atonia is lost, allowing individuals to act out their dreams. The exact mechanism involves dysfunction in the brainstem circuits, often related to neurodegeneration or neurochemical imbalances, especially involving dopamine and GABA. Pathophysiology of REM sleep behavior disorder, step by step process. 1. Normal REM sleep physiology. In healthy individuals during REM sleep, the brain is highly active, a dreaming pace, but the body experiences muscle atonia, temporary paralysis. To prevent physical enactment of dreams. This atonia is mediated by inhibitory signals originating from the sublaterodorsal nucleus SLD in the bones, which project to spinal motor neurons. 2. Disruption in brainstem inhibitory pathways. In RBD, there is damage or dysfunction in the brainstem structures responsible for muscle inhibition, particularly the SLD magnocellular articular formation and medullary inhibitory pathways. 3. Loss of REM atonia. The breakdown of these inhibitory pathways leads to loss of REM atonia, allowing motor neurons to remain active during REM sleep. 4. Pressured motor active during REM. As a result, individuals retain muscle tone and motor control during REM sleep, enabling them to move, talk, kick, punch, or jump in response to their dreams. 5. Dream enactment behavior. The dreams in REM sleep are often vivid and action packed without muscle paralysis. The sleeper act out these dreams, sometimes violently or dangerously. 6. Association with neurodegeneration. In many cases, the underlying causes of this brainstem dysfunction is neurodegeneration, especially involving alpha synuclein aggregation seen in Parkinson's disease, Lewy body dementia, and multiple system atrophy. This stepwise disruption of normal REM motor inhibition explains the core features of RBD motor activity during REM sleep and dream enactment and is strong link to neurodegenerative processes. Signs and symptoms. 1. Dream enactment behavior, example talking, kicking, punching. 2. Vocalization such as shouting, screaming, laughing. 3. Sudden, often violent movements during REM sleep. 4. Injury to self or bed partner. 5. Vivid, intense dreams often involving cursing or fighting. 6. Poor sleep quality. 7. Excessive daytime sleepiness. Diagnosis. 1. Clinical history and interview. Detailed sleep history from the patient and bed partner. 2. Polysomnography sleep study confirms REM sleep without atonia. Video monitoring may capture abnormal behaviors. 3. Neurological evaluation to assess for signs of Parkinson's or other neurodegenerative conditions. 4. Questionnaires. REM Sleep Behavior Disorder Screening Questionnaire. Nursing diagnosis. 1. Risk for injury related to physical activity during sleep. 2. Disturbed sleep pattern related to abnormal REM behaviors. 3. Anxiety related to fear of harming self, others during sleep. 4. Impaired social interaction related to sleep related disturbances. 5. Knowledge deficit regarding RBD and management strategies. Medical management. 1. Medications. Clorazepam. First line. Effective in reducing abnormal behaviors. Melatonin. Safer alternative, especially in elderly, helps regulate sleep cycles, adjust or discontinue medications that may trigger RBD, example SSRIs. 2. Management of underlying conditions, example Parkinson's disease. Nursing management. 1. Maintain a safe sleep environment, remove sharp objects, use bed padding. 2. Educate the patient and caregiver about the condition. 3. Encourage compliance with medications. 4. Monitor for signs of injury or distress during sleep. 5. Collaborate with multidisciplinary team, neurologist, sleep specialist, psychiatrist. Treatment options. 1. Pharmacologic. Clorazepam 0.25 to 1 mg at bedtime. Melatonin 3 to 12 mg at bedtime. 2. Behavioral and environmental modifications. Remove hazards, objects from the bedroom. Sleep on a mattress on the floor if needed. Use of bedded bed rails. 3. Treatment of associated conditions, management of Parkinson's or liver body dementia. 4. Discontinuation of trigger medications. 5. Sleep hygiene education. Psychosocial medicine. 1. Cognitive behavioral therapy CBT helps manage anxiety or stress associated with the disorder. 2. Support groups provide emotional support and shared experiences for patients and caregivers. 3. Stress management techniques such as mindfulness, relaxation therapy, or yoga to promote better sleep. 4. Family education and counseling involving caregivers to ensure safety and emotional support. 5. Social engagement encouraging routine social interaction to reduce isolation and promote well-being. Prevention. No guaranteed prevention, but risk reduced or reduction strategies include 1. Avoiding triggers such as alcohol and sedative withdrawal. 2. Managing neurological and psychiatric condition early. 3. Monitoring medications that can precipitate symptoms. 4. Practicing good sleep hygiene. 5. Regular screening in high risk individuals, example elderly males, Parkinson's patients. Conclusion. REM sleep behavior disorder is a serious parasomnia that can lead to significant physical and psychological consequences if not properly managed, while the exact cause remains unclear. In many cases, RBD is often a mark of underlying neurodegenerative disease. Early diagnosis through sleep studies and vigilant clinical evaluation is crucial. Pharmacological treatments combined with environmental safety measures and psychosocial support can significantly improve patient outcomes and quality of life. Thank you. Have a nice day.